Dear friends, in this video, I'm going to talk about the different the patient positioning and the role of early mobilization in ICU. Let us begin with a case, a 60-year-old male, known case of diabetes and hypertension for 20 years on irregular treatment, presents with sudden loss of consciousness and weakness of all four limbs for a day. The GCS score is E1, V1, and M3. Patient is intubated, mechanically ventilated, and resuscitated. The CT head reveals right MCA territory infarct. The patient undergoes mechanical thrombectomy followed by medical treatment. And on day 7, the patient has a GCS of E2, VT, and M4, thereby meaning that the patient has still a long way to go for final recovery. Hence, patient is tracheostomized and put on intermittent pressure support ventilation and TPAs, maintaining saturation between 90 to 95%. Patient is hemodynamically stable. The question is, what is the role of patient positioning and early mobilization on the recovery and how we should go about it? Now, patients repositioning and proper positioning in ICU is very strongly linked to the interventional patient hygiene model. Patient hygiene model is a very important model which has its links with pressure ulcers, which had its links with sepsis, and which has its links with various other mechanical complications. But it concerns primarily on pressure ulcers, ventilator-associated pneumonia, and mobilization syndrome. And patient positioning and or repositioning is strongly linked with the prevention of all those complications. And at the same time, patient positioning is the antecedent of his or her mobilization and early physiotherapy, which are part of the ABCDEF bundle. Earlier it was ABCDE bundle. Now it is ABCDEF bundle. So just to recapitulate, in ABCDEF bundle, A stands for assess and manage pain. B stands for both SATs and SBTs, that is spontaneous awakening trials and spontaneous breathing trials. C stands for choice of sedation and analgesia. D stands for delirium assessment and management. E for early mobilization and exercise, and F for family engagement. So E, that is early mobilization and exercise, is mentioned in this ABCDEF bundle. And technically speaking, positioning is also a part of this bundle, a part of E. So the potential benefits of positioning in critically ill patients have been realized for many years. It is not something new. But the interpretation has changed over time, and at different points of time, different beneficial effects of appropriate positioning has been identified. And at certain times, even when there is no benefit, the same has been found in the studies. So a lot of logical explanations have been replaced by scientific rationale and scientific evidences. So the common positions which we know in bed are the supine position, prone position, the Fowler's position, Sims position, and many more. But out of this, Fowler's position is the commonest position that is advised in patients in the ICU. Very few patients are on supine position. Even fewer are on prone position, especially when they are having ARDS, moderate to severe ARDS, and are on therapy. And Sims position is something quite unheard of in the ICUs. It is primarily in the OT that during surgery, the patient has this position. So Fowler's position is the most common position, with the knees either straight or slightly bent and the head of the bed between 45 and 60 degrees. Now, recently in 2024, intensive care medicine has published a guideline on positioning and early mobilization in critically ill by an expert panel. And in this video, I'm going to share with you some of those findings and also explain them, the basis of such recommendations or of the guidelines. Now, why should patients receive upper body elevation? What is the biggest advantage of putting the patient in this position? Now, upper body elevation reduces the incidence of VAP and duration of ventilation compared with the supine position, but it does not affect the ICU or the hospital length of stay and mortality. But numerous studies and meta-analysis have shown that it has reduced the incidence of VAP and duration of ventilation, so it is advisable. Respiratory changes result in increased oxygenation by maximizing chest expansion, minimizing abdominal muscle tension, and minimizing the effects of gravity on the chest wall. Therefore, they are useful maneuvers for patients with mild to moderate respiratory distress. There is one more position which is called high Fowler's position, where the head of the bed is kept between 60 to 90 degree, and this position is particularly useful during placement of orogastric and nasogastric tubes, because this position reduces the risk of aspiration. So upper body elevation in patients with brain injury should be individualized. It is not recommended in presence of raised intracranial pressure, but even if intracranial pressure is not raised, or there are signs are missing, but the intracranial pressure is not monitored, then one needs to individualize its role. So including regular cerebral perfusion pressure and ICP monitoring are not there, then this position should not be used in patients with acute brain injury. What is the role of lateral position in the ICU patients? Lateral positions do have some role in patients who have one-sided lung injury, so that if that particular side is kept up, the aeration of lungs in that part of the injured part will be better. But respiratory changes from lateral weight of the mediastinum and cephalad displacement of the abdominal contents usually result in decreased pulmonary compliance. And lateral decubitus position favors ventilation of the non-dependent lung. So therefore, it is important to note that one patient who has a spontaneous ventilation versus another patient who is on mechanical ventilation, then the benefits and harm will be just the same, or will be applicable depending upon the nature of ventilation. Although patients with lateral positioning had a lower incidence of VAP, there is no significant difference in 28-day mortality. And also, the important thing is that there is continuous lateral rotation therapy. If one is practiced, there is a reduction in nosocomial pneumonia in patients who are put on prophylactic continuous lateral rotation therapy versus usual care. But it has to be seen that there is no effect on the existing pneumonia or even on mortality. And there is also no difference in microbiologically confirmed VAP. So lateral position in ICU patient is not much advisable unless there are specific problems related to one lung, and that lung needs to be kept above. Next important position that we need to know is the prone position, or essential for ventilation in prone position. Now, prone positioning of 16 hours daily for patients affected with ARDS with a duration of ventilation less than 36 hours and a PF ratio of less than 150 millimeters of mercury showed a significant survival benefit for 28-day mortality. And this was the PROSEVA trial, which showed this enormous benefit. Now, according to available evidence, a minimum duration of 12 hours seems necessary for a positive effect of prone positioning, with each additional hour further improving it. So we know that sometimes, although it is documented on paper that the duration of 12 hours, but it is often not complete. It is often not fulfilled. So in those cases, there is every reason that the results of prone ventilation may not be evident. In non-responders, the pragmatic experts recommend that prone positioning therapy should be terminated after 2 unsuccessful attempts. By unsuccessful, we mean that when there is no increase in saturation despite putting the patient prone. So they should be unsuccessful patients, they should be terminated. And limitation of tidal volume is necessary. for the mortality benefit from prone positioning, and most of the meta-analysis have used a cutoff value of 8 mils per kg of predicted body weight. So this is also something very important. But due to lacking evidence, the possible positive effects of prone positioning in obese patients should be critically evaluated. So if the patient is obese, we cannot expect that the prone ventilation is going to give extra benefit. But still, other factors should also be taken into consideration. Now, further considerations for prone positioning should include volume status of the patient's determination and further optimization prior to positioning. Now, prone positioning and PEEP, they often have an additive effect on improving the oxygenation. So if there is a scope to increase the PEEP, the same can be done. Prone positioning significantly increases the risk of pressure ulcers, and therefore it is recommended to regularly conduct or inspect certain vulnerable locations. So if they are detected early, they can be treated early, and the chances of morbidity would be less. Prone positioning additive to VV ECMO can cause significant survival benefit. The large volume ECMO centers do claim that, although there are not very big studies, but they should be allowed only in experienced centers. So unless the center is well enough experienced, they cannot give the best result. So important to note that a multi-professional consensus should balance potential benefits and risks in cases of open abdomen, unstable spine, increased intracranial pressure, and in cardiac arrhythmias or dysrhythmias. So if we go by the recommendations, we find that the level 1 recommendation exists for upper part of the body greater than 40 degree in intubated patients, considering possible hemodynamic side effects and increased risk of pressure ulcers. And although they had recommended this, there was suggestion, the level of evidence being 4, and so it was a level of evidence 4 suggestion, and for guideline adaptation, they say that upper body elevation in patients with increased ICP to achieve the most favorable effect on cerebral perfusion pressure. So this has a level of evidence is 4. So it can be considered as a poor evidence. The guidelines suggest avoiding upper body elevation with flexion of the knees and hips in patients with elevated intra-abdominal pressure as at its risk, and suggest favoring the anti-Trendelenburg position for upper body elevation. Now, this is also a level of 3, and guideline adaptation has also included this point. Then they say that we are unable to make a recommendation for or against lateral positioning for the prevention of pulmonary complications without causing any lung damage or lung injury. And the level of evidence is 3. So with the level of evidence is 3, it is very difficult to find. Next is the recommendation is that we recommend regular modification of positioning to avoid flat supine position as an inappropriate form of positioning. And we suggest not to use continuous lateral rotation therapy and recommend prone positioning in the invasively ventilated patients with ARDS and impaired arterial oxygenation. In addition to this, there are also other recommendations which suggest that patients should be stabilized, hemodynamically optimized, the volume status optimized prior to prone positioning. The use of catecholamines is not a contraindication for prone positioning. They also recommended that patients at risk of ICP are monitored continuously or closely during the prone positioning. The head should be positioned in a central position and lateral rotation should be avoided, because if there is mild slip or dislocation of the spine, displacement of the spine, then that becomes full. So the guidelines committee suggested that prone positioning should only be carried out in individual cases after considering the risks and benefits, and it should be there should an interdisciplinary fashion can make the job easier. The interdisciplinary fashion should include the conditions like open abdomen, spinal instability, increased ICP, cardiac arrhythmias or dysrhythmias, and hemodynamic consequences, as well as shock. And the guidelines also suggest, they don't recommend, they suggest terminating prone positioning if improvement in supine oxygenation persists 4 hours after repositioning, and the PF ratio of more than 150 with a PEEP of less than 10 centimeter of water and FiO2 of 0.6 remain unchanged. There are also other recommendations which suggest that prone positioning should be discontinued if at least 2 positioning attempts have been made. And the guidelines committee also recommend complete rather than incomplete prone positioning, as there is no evidence to improve clinical outcomes for incompletely prone position, and complete prone position has a stronger effect on oxygenation. There is also other recommendations, like we recommend to carefully examine these areas for pressure ulcers during prone positioning to minimize the risk of development. And the guidelines is unable to make any recommendation for the duration of awake proning. Awake proning is something which is also strongly advocated. It was used during the COVID, and then its benefits were realized. And even today, a lot of physicians do practice awake proning. Now, next point comes to mobilization. Now, when early mobilization should start in the ICU? Early mobilization is defined as starting within first 2 to 5 days of critical illness or injury, or within the first 24 to 72 hours of ICU admission. Now, this involves a series of planned movements that progress in a sequential manner, starting with simpler activities and advancing as the patient's condition improves. Now, this includes in-bed activities like passive and active range of motion exercises for the joints and breathing technique, functional activities like sitting at the edge of the bed, transferring to a chair, and eventually walking. Then novel techniques like cycle ergometry for in-bed stationary cycling, and TEMS can be used particularly for unconscious patients. So whatever it is chosen, strategy is chosen, a coordinated approach involving physiotherapists, nurses, and respiratory therapists is essential for implementing the mobilization plan. So this is the ICU mobility scale, which is often used as a standard or a reference to guide about how to go ahead with mobility. So classification, there are 11 points, 0 to 10. So if we count 0, it becomes 11. Now, this is important because there are certain numbers which can be useful. Now, walking away from the bed or chair by at least 5 meters, so that is also something which is a borderline patient from those who are from India, etc., and other places. Now, walking with assistance of 2 or more people. Now, this is also a very important aspect of ICU mobility scale, which people need to look for. So it is a 0 to 10 point, 11 item categorical scale, and it is used to measure a patient's highest functional mobility level from performing passive exercises in bed like score 0 to independent ambulation without any gait disorder. Now, which patients should receive early mobilization? Patients who had been functionally independent prior to ICU admission, they are the ones who derive maximal benefit of early mobilization. And this is particularly when we look for outcomes like duration of ventilation, ICU length of stay, muscle strength, and the ICU acquired weakness. The adverse events of early mobilization in patients undergoing CRRT or ECMO is rare and self-limiting, but only centers with necessary expertise in ECMO therapy should perform such mobilization during ECMO. Very early mobilization can be harmful in stroke patients, and even the brain may herniate. Assessing respiratory and cardiovascular reserves before mobilization is a wise way to adjust the intensity appropriately if necessary. Next question is, do mobilization assist devices or robotics have a beneficial role? Now, supine cycling is the most studied assist device. However, it is often evaluated as part of heterogeneous study protocols concerning intervention, control group, and outcomes. So the combination of bed cycling with mobilization showed no improvement in the functionality or quality of life. Then neuromuscular electric stimulator. This is a NMAS. It is a non-invasive transcutaneous application of electrical stimuli that leads to active muscle contraction independent of patient's cooperation. Now, this therapeutic option can be particularly beneficial during the early phase of critical illness. But one has to remember that this neuromuscular they should be avoided or used carefully, or better to avoid in patients who are at risk of ICP elevation. How should a mobilization session be prepared? Before mobilization, treatment team and patient should be informed, and therapeutic measures like lines, tubes, extensions, they should be adjusted for safe continuation. Alarm limits should be modified for safety, and additional staff support should be considered. And these aspects should be planned individually based on patient's clinical background. Now, the patient's status, consciousness, and vital signs should be closely monitored during mobilization. In ventilated patients, essential parameters should be continuously monitored. So, how should a mobilization session is prepared? The interaction between exercise, energy consumption, and diet is unclear. Now, there are certain recommendations like starting early mobilization of ICU patients within 72 hours of ICU admission. Then the authors also recommended that the hospital management provides the personnel and material conditions to enable mobilization in line with these recommendations. And we recommend the implementation of early mobilization in all patients who were previously functionally independent. And also, the authors say that we suggest performing early mobilization in critically ill patients who were functionally dependent prior to the ICU admission. So, a whole bit of recommendations are there which can fit into most of the conditions. Second, recommendation 2, the protocol-based approach for implementing mobilization with active and passive components. So the authors in the guidelines suggest integrating safety criteria like pulmonary or cardiovascular conditions into the mobilization protocol. For preparing a mobilization session, it is suggested that patients should be informed, enough staff should be there, and securing or extending artificial airways, intravenous lines, or other drains if they are there in the patient's arms. They recommended stepwise mobilization to the highest possible level, and the stepwise mobilization is always better than haphazard forms of mobilization. The guidelines, they do not make any recommendation either for or against combination of mobilization with increased protein intake, and so also is not able to recommend for or against in the involvement of relatives in early mobilization plan. So there are certain recommendations, and some of them have level 1 evidence. The level 1 evidences, they suggest considering supine cycling as part of early mobilization only when functional trait is not sufficiently possible. Now, there are different ways to understand functional training. So it is not always the same as it may appear. So we'll see. The recommendation is that we suggest considering neuromuscular electrical stimulation, EMAS, for early mobilization of critically ill patients. And the authors also recommend continuously monitoring ICP in patients with already established intracranial pressure. So if you look into early mobilization in the ICU, you have to secure patient cooperation, and this is totally related to the patient. Position the patient appropriately, know when mobilization is inappropriate, and perform functional mobilization. When it relates to the staff, we have to educate and treat them, communicate and collaborate, distribution of function focusing on teamwork, assess safety, document outcome, and all other activities that is under planning. So thank you very much.